Good morning, good afternoon, good evening. This is Lieutenant Colonel Alan Jones, and this is part 3 of a 3-part series on health services for special populations, or Chapter 11 out of your U.S. Healthcare Systems book. So we're going to start off with rural health. So rural health, there is an issue in the United States, meaning there's a great disparity between health services that are in urban areas and then health services that are in rural areas. And the latter, the rural, have much less services. The health outcomes for a lot of the population in the rural environment have poor health outcomes. And so with the Health Professional Educational and Assistance Act, that was an act passed by Congress to incentivize physicians and non-physician practitioners to practice in areas that are deemed rural because there's a need for that population. There's 3 types of health profession shortage areas, or the HPSAs. That's in geographic areas, different rural areas of different states, among different population groups that don't have access to care, and even some medical facilities that just don't have the services or the tax base to fund those services to provide their population. So medically underserved areas. So what does that mean? So there's a set percentage of the population below the poverty income level. On average, rural Americans have a lower income than those in urban areas. Or there's a higher percentage, or the percentage of population 65 years and older oftentimes is pretty big, so that the health needs to meet that population. Infant mortality rates are higher in medically underserved areas. And then with the number of primary care practitioners per 1,000 population. So just like in the military, often we can move physicians and non-physician practitioners around for the needs of the force, even though the population requirements are not always there. So migrant workers. So migrant workers are a significant part of the population. Usually they're agricultural workers that come up from Mexico and other Central American countries that come and do work. The work isn't all year round. There's community and migrant health centers, and these are really for a lot of the positions that just aren't yearly work. And then there are Rural Health Clinics Act, which allowed PAs, nurse practitioners, clinical nurse midwives with rural clinics to practice without the direct supervision of a physician. And then what was happening is, in many of these places there just wasn't a physician available, and so they allowed non-physician practitioners, the PAs, the nurse practitioners, the certified nurse midwives, to practice in these even if a physician wasn't available. And it allowed reimbursement by Medicare and Medicaid. Homeless. So approximately 1 in 200 people became homeless in 2001. Out of the adult population, it's almost 2 to 1, male to female. Almost a quarter of the homeless population are children under the age of 18. 35% of that population are families with children, and 14% are veterans. And again, those who have served represent less than 1% of the United States, yet they represent more than 14% of the United States when it comes to homelessness. And oftentimes there's some factors that lead to homelessness, and that's the shortage of adequate low-income housing. So as the economy grows and areas become more money becomes into those areas, low-income housing is pushed out. And again, the homeless have barriers to health care, whether it's getting access to proper health healthcare, whether it's even available or whether it's financially too much for them to afford. Mental health, there's barriers to mental health care. There is a challenge. Uninsured and mental health, again, they don't fall under EMTALA oftentimes, and so a lot of those diseases go untreated. The chronically ill, chronic diseases are the leading cause of death in the United States. And again, that's maybe an okay measure now that Americans live long enough to suffer from chronic diseases. But just like we talked about last week, these chronic diseases result in limitations of ADLs or activities of daily living, and really have a significant impact on not only their health but their life. And a treatment accounts for treatment of chronically ill. The chronically ill population accounts for 86% of all healthcare costs. So chronic disease is a significant cost for the U.S. healthcare system. HIV and AIDS. And so HIV and AIDS really caught our population, our country around the late 80s, early 90s. Fortunately, there have been a lot of advances in the medicines that can take care of the HIV/AIDS population, so many people can be managed with their disease for a long time. And a lot of that's been education too of how you contract HIV/AIDS. HIV rate is greater in rural communities and is a more significant problem in children. So HIV/AIDS related issues, still a push for need for research, the public health concerns as far as how that disease is spread, both through intercourse or drug IV use. And then there's discrimination, again, with those two, intercourse and IV use, about the population that affects. And then provider training to ensure that providers take the right safeguards and know the most up-to-date research to take care of the population. Cost of HIV and AIDS, significant. You could see that in figure 11-12 in your book. AIDS is characterized by a gradual decline in physical, cognitive, and emotional function. So like any other chronic disease, it's more strenuous on the person as it progresses. And just like it said, as the disease progresses, more people become disabled and rely on public entitlements, again, which is a great cost for the healthcare system. So in summary, our population has challenges and barriers in accessing healthcare services for certain population groups. And so there is a disparity among groups of the population that access care and, of course, have different health outcomes. So it's not even across our country. And the health needs of these population groups vary, depending on many factors. And the gaps between population groups and the rest of the population groups oftentimes are growing, or when or they aren't closed as our technologies can enable those things to close. But again, there are significant barriers and challenges our country faces with addressing the needs of certain population groups. And that concludes Chapter 11.